Thank you, everyone, for visiting our vendors during the break, and thank you for coming to the 4th Annual Tatar Family Foundation Cancer Symposium. I've really enjoyed our first two talks, and our third will be no exception. Our final speaker is Dr. Randal Henderson from the University of Florida Proton Therapy Institute. Dr. Henderson completed his medical training at Texas Tech University Health Science Centers and his postgraduate medical training at the University of Florida. He's the medical director and associate chairman of the University of Florida's Department of Radiation Oncology in Jacksonville and associate medical director of the University of Florida Proton Therapy Institute, where he is the principal investigator on several prospective trials in the treatment of prostate cancer. Dr. Henderson.
I'd like to thank Dr. Kyler and Mr. Tatar for the invitation to speak at this very excellent conference. And today I'm going to be speaking about proton therapy for prostate cancer. I'll be dividing our discussion into a discussion of the basics of radiotherapy for those of you who do not have a radiotherapy background, a little bit about proton therapy versus X-rays, and the difference between those, and then the bulk of our time will be spent talking about proton therapy treatment of prostate cancer. So one of the questions that we frequently get is how exactly does radiation affect cancer cells? How does it kill cancer cells? And basically the radiation will interact with the molecules and displace an electron, transferring that energy to an electron. That electron will then interact with another molecule like a water molecule and form a free radical. And that free radical is very reactive, and that can bump into a DNA and cause damage, a single strand break or a double strand break in that DNA. And this type of damage can occur in cancer cells and in normal cells, but the normal cells have a repair mechanism that can repair most of that type of damage within a matter of hours. Cancer cells have a defective repair mechanism, so that damage tends to accumulate and becomes much more of a problem in the cancer cells, and you're hoping over the course of several weeks of radiation therapy to accumulate enough damage in the cancer cells to cause them to die when they try to divide. There are some principles of radiation oncology which I think are important to understand. First of all, the damage from radiation is not selective. As I mentioned, this process takes place in normal cells and in cancer cells in the area where you focus your radiation. And the higher the dose of radiation that you deliver, the more likely you are to kill the cancer cells. So giving higher doses is more likely to result in a cure. But those normal cells that are exposed to this radiation effect as well are more likely to have a complication with the higher doses of radiation. And sometimes in giving enough radiation in order to have a high likelihood of curing a cancer, you're going to wind up with a complication of those normal tissues, so that may be one of the prices you pay for a cure. The therapeutic ratio actually describes this concern we have about trying to increase the cure rate by increasing dose, while at the same time trying to keep the risk of a complication as low as possible. And that's really what we refer to as the therapeutic ratio. A large cure rate, a low complication rate would result in a large number for that ratio. And really that's the goal in our research and trying to move the field forward, is to improve that therapeutic ratio. This actually displays that in graphical form. And if you look on the right side of this diagram, on the horizontal axis, we're talking about the dose of radiation, and on the vertical axis, the likelihood of producing either tumor control or a complication. And if you're dealing with a situation where those two curves are very close together, then if you have a high likelihood of cure, you're going to have a high likelihood of complication. So theoretically, you would like to separate those curves as much as possible. And on the left-hand side, it shows, in fact, when you do that, you could, as you increase the dose, wind up getting a fairly high tumor control and yet a low complication rate on the tissue complication curve. And ideally, you'd like for that complication risk to be below 5% and with a very high control rate. And there are some things that we can do to try to influence the separation of those curves. You can use biologic response modifiers like radiation sensitizers or radioprotectors. You can alter the fractionation schemes. But by far the biggest impact over the decades with radiation therapy has been utilizing ways to try to more effectively confine the high dose of radiation to the target that you want to treat and minimize the dose of radiation to the normal tissues that surround that area. So by improving that dose distribution, and particularly the lowering of the radiation dose to the normal tissues is what we call the integral dose, the dose to normal tissues surrounding the tumor area. And that includes all of the normal tissues. Some of them will be getting a fairly high dose. If they're directly adjacent to the tumor you're targeting, then they may be in the high dose area. But it also includes those tissues along the beam paths that are getting exposed to radiation as each of the beams that you're using to create that high dose travels through the body on its entrance and exit. Dr. Herman Soot is one of the giants in our field who was at Harvard for many, many years. And in 2001, he delivered the keynote address to our national organization looking at this very idea of therapeutic ratio, integral dose, as it applies to radiation and moving our field forward and proton therapy as well. And he made some points I thought that were relevant to our discussion today. First of all, he said it was very important to understand that there is no advantage to any patient to have radiation exposure to normal tissues. That seems very basic, but there is nothing good that comes from treating normal tissues with radiation if you can avoid it, and that direct complications from radiation never occur in unirradiated tissues. And then also that a smaller treatment volume being superior to a larger volume of normal tissue being treated is not a research question. And sometimes even today that becomes a point of confusion. Really the question you need to ask is not, is it better, but you ask how much better is it and what's the price you have to pay for that improvement, to whatever degree it is an improvement. So, whoops. Proton therapy versus X-ray therapy. The difference between these two types of radiation was recognized in the early 1900s. Dr. Bragg noticed that protons actually stopped in tissues, whereas X-rays kept on going, that was a difference. The other thing that he noticed that was different between protons and X-rays was that protons deposited most of their energy at the very end of their beam path, and X-rays, on the other hand, deposited most of their energy at the very beginning of their beam path as they entered tissues. And this depicts that in a graphical way. This is a couple of CAT scans. This patient is lying on their belly, so this is their back, this is the spine, the kidneys to either side here. This is the bowel and the liver over to the side. So if I was treating a patient like this who had a spine tumor with a single beam of X-rays coming from the back and compared that to what I would be able to do with protons, the first obvious difference is that the protons stop. And that's an important difference. It allows me to totally avoid having radiation effect on the bowel that's distal to the tumor. I can reduce the amount of radiation to the kidneys that are adjacent to that area. But the other thing that it illustrates in this color wash is where the dose is deposited, and the red coloration is where there's the highest energy deposited from the radiation beam. The yellow, green, and blue, lesser and lesser doses being deposited. And if you look closely, you can see that in the left-hand side, the red area, the highest energy is deposited right here rather than in the area of the tumor itself. Whereas with the protons, the red area is directly in the location of where the tumor is And so we're able to put the dose right where we want it. Now that can actually be described in a graphical form, depicted in a graph form. So if we were to, on this horizontal axis, display the depth of the radiation from skin surface on over to exiting the other side of the body to the right. And on the vertical axis, we plot how much energy is deposited at any particular depth. And we look at an X-ray beam coming in from this side. We see that the maximum amount of energy is going to be deposited within the first few centimeters. And then the amount of energy declines as you go through the body and then continues to deposit energy all the way out the back. So if you're trying to treat a tumor that's located deeply within the body, you're actually giving more radiation with any individual X-ray beam. You're giving more radiation to the normal tissues than you're giving to the tumor itself. And you can't change the physics of that. That is what you get with X-ray. So that's a limitation of the X-ray approach. On the other hand, if you have a proton beam entering, you get a lower dose to the tissues between the skin and the tumor. You get the maximum amount of radiation at the tumor itself, and then the radiation stops, which means that there's no radiation beyond the tumor. So what's depicted in red is the amount of excess energy deposited by an X-ray beam in normal tissues that you would like to avoid with an X-ray beam that you can avoid if you use a proton beam to treat that area. So this advantage of proton therapy over X-ray treatment has been known for a long, long time, and but because of the cost of building proton facilities, it was really only applied to cancer patients in research-based facilities back in the 1950s. The first treatment center dedicated to the treatment of cancer patients was opened in the early 1990s at Loma Linda University in California. Our facility was the 5th of its kind in the country and opened in 2006. This displays, with the orange dots, the 14 proton facilities that are currently operational in the United States, and the blue dots, the 10 additional facilities that are under construction. This schematic, which doesn't display terribly well, but it does show the heart of the proton facility, and I'll show you some real pictures of the individual components in just a moment. But the cyclotron at the upper portion of the field is a very large electromagnet with a hollow core, kind of donut-shaped hollow core, and there's a deep vacuum within that cavity. And you begin with protons. You can break a water molecule and the hydrogen apart and get protons, and you inject those into this hollow cavity and reverse the polarity very rapidly on this electromagnet. And because the protons are positively charged, they begin to move in a circular fashion, going faster and faster. And you can split them off with magnets to then travel down a pipe where the vacuum is continued, and that pipe is surrounded by focusing magnets and bending magnets, which can influence a positively charged particle. And then it's directed down this beam line behind these gantries that are located in treatment rooms, and the protons can be then directed to the area that you want to treat in any given patient. So this shows what the cyclotron actually looks like with a real picture, and this is the beginning of the beam line here, just adjacent to it. This is that line going behind the gantries and that pipe that I mentioned to you with the electromagnets that are keeping the beam focused and directed. This shows one of the gantries within a treatment room as it's being constructed at our facility and gives you an idea of the scale. The gantries are 3 stories high because that's how quickly we can bend the proton beam that's traveling very, very fast. There's a finite limit to how rapidly you can curve those beams. But with that curve and the gantry rotation, we can bring that beam from any different direction to focus on a patient who's lying on a treatment table with a beam exiting through this treatment nozzle. And this shows a patient on the table. This displays some of the cancers that we have prospective or we have clinical trials available at our institution. We're excited about our pediatric cancer program. At this point, we have the largest pediatric proton program in the world at UFPTI. We have a shared research interest with St. Jude's Children's Hospital and treat children from their institution. They're currently building a facility, a Proton facility there. And we have contracts to treat children from Great Britain, Norway, and recently signed a contract with Canada. All of those countries do not currently have protons, but are in the process of developing protons. And then we are excited about some of our newer programs. Our breast program's fairly new. We have a protocol for macular degeneration, and in sheer numbers, our prostate program is the largest, but as these other programs have been developing, the percentage of prostate patients has declined some over the years. But I would like to share with you some of the things that we have learned from our treatment of prostate patients. And our discussion will focus on, first of all, a brief comparison of X-rays versus protons in the treatment of prostate cancer. I'm going to talk a little bit about an article that concluded that proton therapy was inferior to X-ray treatment for prostate cancer that got a lot of publicity, so I'd like to comment on that. And then we'll spend the bulk of our time talking about outcomes, the majority of which would be from our institution. So we've actually come a long way in the field of radiotherapy from the early days of X-rays. Early on in the 1970s and earlier, we were using very simple field arrangements, and if you remember our color wash that we talked about before, the red area being the hottest, this is not very well focused. And this particular CAT scan has the patient lying with the stomach in the front, so he's lying on his back. The hips are on the sides here. I think my pointer's dying. The white area in the center is a balloon in the rectum, and just in front of that area with the little bright marker that you can see staring at you there, the prostate is in that region. And then as we progressed in our technology and we began to use multiple fields, like in the 1980s, we were able to pull that high-dose area in a little bit better to the area that we were concerned about, at the expense of actually treating a bit more of the normal tissues in the process. And then with 3D conformal radiation and arc therapy, we were able to pull it in a little bit better, but again, at the expense of normal tissues getting more radiation. And then with IMRT in 2000 and beyond, we've really tightened up the high-dose area, and that actually has allowed us to decrease the complication rate related to the high-dose area because it's more confined, and that's a good thing. But the trade-off is this higher dose of radiation to surrounding normal tissues, and remember, no good thing comes from that. And so we have to wonder what the cost might be from that trade-off. Then the IMRT treatment has certainly been an area of active development. There's quite a number of different treatment machines that you sometimes may hear about that can deliver IMRT, and some of these would be machines like Rapid Arc, Novalis, TrueBeam, tomotherapy, CyberKnife, and they're all very sophisticated machines that are at the heart of each one of them, though, it's a way to deliver multiple beams of radiation from different angles, all focused on the prostate region. But what they all have in common is that each of the beams that they direct at the prostate are the same 6 million electron volt X-ray beam that have these same properties that we talked about before of depositing more of the energy between the skin and the target than to the target itself. So that's just kind of a limitation. We've become very sophisticated in trying to target our dose and doing a very good job of it, but we bump up against that limitation of the physics of X-ray treatment. And that's where protons have an advantage. So when we look at protons being delivered from lateral fields at the prostate, we can deliver a high dose of radiation to the prostate itself and at the same time reduce the amount of radiation to the surrounding normal tissues. So IMRT redistributes its energy from the targeted tissue and to non-targeted tissues. Radiation actually reduces the dose to non-targeted tissues. So this, I mentioned this article that concluded, so how could you conclude that protons are going to be inferior to X-ray treatment in prostate cancer. Well, this article was published in the Journal of the American Medical Association. It was highly publicized, and it was a retrospective review of a couple of databases, the SEER database and Medicare database. And they were able to look at over 6,000 patients who were treated with the older X-ray techniques of conformal radiation, over 6,000 patients who were treated with the more modern technique of IMRT, and then over 600 patients who were treated with proton therapy. And as they analyzed this series, what they concluded was that IMRT was better than the older X-ray techniques because they saw less rectal toxicity, fewer hip fractures, but more erectile dysfunction than they had. But still, overall, they felt that the conclusion was that IMRT was better. And then with regard to protons, when they compared IMRT to protons, they found that there was less rectal toxicity with IMRT than with protons. And so that was the takeaway message that IMRT was less toxic than proton therapy. So I think that it's important to actually look at some of the specifics in this particular article to get a better understanding of why I don't think this was a well-done study. For one thing, when you do a database study like this and you don't have patients that you're following and scoring toxicities on, you have to come up with surrogate endpoints. And so that's actually what they did, is they looked at the Medicare claims and they said, well, what can we look at? Since we don't have real toxicity endpoints to look at, what could we look at? And so one of the things that they decided to look at were colonoscopies. And so they made the assumption that if a patient had had radiation and they went on to have a colonoscopy, that they would assume that colonoscopy was done because of a complication. And so it was scored as a complication. What they didn't say, or what they didn't provide you with, is any information regarding the dose of radiation that a patient receives, which is the thing that correlates more highly with complications than anything else. And during the time of that these patients were treated and their data was entered into these databases, it was a time where there was a lot of research being done on dose escalation. And in fact, there were several classic trials that were performed during this time that showed that higher doses of radiation were more effective at curing cancer than lower doses of radiation. And in fact, Loma Linda was active in some of those trials, one in particular. And so since almost all of the patients, the proton patients that were put into this study were from Loma Linda, very many of them were on this dose escalation trial using higher doses. And also built into that, because they were concerned, this was in the early days of doing this dose escalation, because of their concern about how is this going to work out, they built in periodic colonoscopies in following their patients. So, which was not being done by physicians who were treating with IMRT and community practices to sometimes the lower doses that were standardly being used prior to these dose escalation trials. And so every time Loma Linda followed one of their patients and did one of these colonoscopies to check to see how well they were doing, they were scored as having a toxicity. But this wasn't discussed in the paper. Also, when they concluded that the toxicity rate was actually quite high with proton therapy, they didn't mention that, oh, by the way, Loma Linda has published their toxicity rates by following their own patients, and they're actually quite low, and these figures don't match. I would have expected they would have pointed that out and offered an explanation as to why that might be, but in fact, that wasn't commented on at all. So we would conclude regarding this study that it's a flawed study, and it's not consistent with the actual data from Loma Linda or from our institution regarding rectal complication rates, and we'll look at that in just a moment, those numbers. So outcomes. We're going to look at the outcomes for a variety of different areas, and the first one is rectal and bladder toxicity. These are, I mentioned the dose escalation studies, and some of the very first indication we had that rectal toxicity actually might be quite low with proton therapy came from Loma Linda. These 4 dose escalation trials all looked at a lower dose, kind of compatible with the doses that were given in earlier years, and then a higher dose, which is more compatible with what has now become the standard of care. And patients were randomized between a lower dose and a higher dose. And the first three of these trials were studies that were done with X-rays. The last one was a study that was done with a combination of X-rays and protons, and that was one conducted primarily at Loma Linda. And what they found on these 4 trials was that in the higher dose arms, they all had a higher biochemical control rate at 5 years than with lower doses, and that didn't surprise anyone. What was interesting, though, is that along with this higher control rate, we also saw higher rectal toxicity. Again, not a surprise. But that was true in all of the X-ray trials, but in the Proton trial, there was no difference between the lower doses and then the higher doses in terms of rectal toxicity. That was a surprise. We would have expected the toxicity to have been higher, but that was some of the first evidence that, in fact, maybe protons were sparing tissues better and allowing us to go to a higher dose more safely than we could with X-rays. Now, looking at data from the University of Florida, we've published data on patients who were treated on our first 3 trials of low, intermediate, and high-risk patients. Those patients received 78 cobalt gray equivalent to 2 cobalt gray equivalent per fraction over 39 fractions. We have a median follow-up of just over 5 years. And I'll be comparing some of this data with IMRT data because we were curious as to how our data stood up in comparison with very good series like that from Memorial Sloan Kettering, which had similar follow-up and similar doses. Their daily dose per fraction was 1.8 instead of 2, so it's a little softer dose, but they make up for that by going to a little higher total dose. But all in all, very similar types of effects from those 2 types of approaches. When we looked at the grade 3 toxicity in our patients, we scored these patients as we followed them with the common terminology criteria for adverse events, version 3. And what we found was that our rectal toxicity rate was 1%, our bladder toxicity rate 4.5 or 5.4%. And in the patients who were on our high-risk protocol that included concomitant low-dose Taxotere along with the proton therapy and 6 months of hormonal therapy, we had a few hormone-related grade 3 toxicities that were confined to those high-risk patients. When we compared that with the series from Memorial Sloan Kettering, we saw that their toxicity rates were a little lower than ours for the GI and GU toxicities. But we felt it was important that they actually didn't use the same scoring system. This common terminology criteria for adverse events, version 3 that we use was all that was available or the latest available when we treated and tracked our patients. But more recently, a newer version came out that's version 4, and actually the definitions are quite a bit different. Version 3, you scored toxicity based on what kind of intervention did you have to do to treat a toxicity, and the severity of the intervention helped drive how high a score you put on the grade of the toxicity. With version 4, they changed that, and they said their definitions are tied to how big an impact does this toxicity have on the activities of daily living, the patient's ability to carry out activities of daily living. So quite different definitions. So Memorial Sloan Kettering had actually gone back retrospectively and applied this version 4 to their patients, so we did the same thing. We went back and retrospectively recategorized our toxicities according to version 4, and we found out that our toxicities stacked up very well in comparison to Memorial Sloan Kettering, a little lower, certainly not more. And then we've also looked at patient-reported outcomes. Now, those toxicities I just showed you are ones that are scored by physicians based on what the patients are telling them, and then you categorize those based on standardized definitions. But it's becoming more and more important in the literature to look at patient-reported outcomes where the physician's not in between the patient and the toxicity they described, they're actually scoring themselves. And we did a comparative effectiveness study looking at over 1,200 of our patients treated with protons and comparing them with data on patients treated with IMRT, and that data was in the PROSQA database. And when we looked at a variety of things, bladder function, rectal function, sexual function, we found that there was no statistically significant difference in any of those domains except for the domains of bowel urgency, frequency, and incontinence. And in that area, we found a statistically significant reduction in patients that were treated with proton therapy as compared with the IMRT patients. And those rates were about half what they were with IMRT. Now, why would that be? We didn't see a difference in, say, rectal bleeding between IMRT and proton therapy, but we did see a difference in this urgency and frequency. And we think that this may have to do with again, back to where the dose is deposited and what is it that you're affecting. If we're talking about rectal bleeding, well, rectal bleeding is driven by the high dose of radiation to this anterior rectal wall. And if you can see that red area, and again, just a reminder that white structure is a balloon that's in the rectum that's filled with saline. It shows up white. And so this anterior rectal wall, you can see just a very small portion of it is getting a very high dose. And the way the body responds in that area is to develop new tiny blood vessels as the healing process goes on to help nourish those tissues. But those blood vessels can break, and you can wind up 9 months, a year down the road having streaks of blood in the stool or in the water and with bowel movements. And that we would not expect to be any different between proton therapy and IMRT because the volume that it receives that dose is very, very similar. But on the other hand, if we're talking about the irritability of the rectal area that might influence frequency or urgency, if you notice with the IMRT, you're treating the entire circumference of the rectum with radiation moderate doses, whereas you're sparing the majority of the rectum any dose with proton therapy. And so you might imagine that the recovery and function of those tissues in the long run might be better with proton therapy. When we look at this from a side view, this is actually a beam's eye view for proton therapy with the sacrum here and the coming in from the side. The red area displays where the prostate is. The white area, again, is the rectal balloon. And with the IMRT on the left, you're seeing the entire circumference irradiated, whereas you're sparing most of the rectum with proton therapy on this side. And we're treating less bladder with the proton therapy than we do with IMRT as well. Another effect is a reduction in the risk of second malignancies with proton therapy as compared with IMRT. And again, this relates to the volume of normal tissue that's being exposed to radiation. But there is a study from Memorial Sloan Kettering by Zalewski looking at the chance of developing a radiation-induced cancer following IMRT or radiation seed implant. And they found that that risk was about 2 to 4% if you looked at the 10 years following treatment with X-rays. There is also a dosimetric study from the National Cancer Institute of Korea, published in 2009, comparing protons to IMRT, and they found that the risk of secondary cancer is reduced 5 times lower with protons than with IMRT, again, because that radiation dose is more confined and is exposing fewer normal tissues to that potential complication. There's also 2 dosimetric studies from Harvard in pediatric tumors looking at this very same issue. How likely is it that you're going to wind up with secondary malignancies down the road? And both of those concluded that the risk was significantly lower with protons than with IMRT. We also were interested in looking at the impact of scatter radiation on testicular function because it's a biologic dosimeter. We were aware that there were 3 studies that had been published looking at the effect of X-ray treatments on testosterone following prostate cancer treatment. And those 3 studies did show a detectable decline in testosterone levels from that scatter radiation. And we did not believe that would be the case with proton therapy, but Dr. Nichols looked at 171 patients with low and intermediate risk prostate cancer patients, and as we tracked their testosterone levels, there was no correlation in those levels following proton therapy. We've since that time done similar studies in 2 other larger groups of our patients and found the same result, that there's no effect. Now, clinically, this is not important, really, but just in terms of the scatter radiation and the effect on normal tissues in the long run, it's another piece of evidence that protons are actually sparing more tissue. We've also seen excellent results in terms of erectile function, and this is a common question that our patients ask about and seem to have a great deal of concern about. And Dr. Hoppe looked at 262 of our patients that were less than or equal to 60 years old. And in those patients, we defined potency as intercourse within the past month or an EPIC sexual summary score of 60 or more, indicating reasonably good function. And in these 262 patients, 86% met that definition of being potent at baseline. And as we follow those patients after their proton therapy, 2 years following treatment, 73% still were potent according to these definitions. And if we looked at the patients who reported being sexually active at least weekly at baseline, they had an 11% decline in the numbers that were still potent. And then also, potency can be affected by a number of other risk factors, including obesity and diabetes. And if we looked at our patients who were potent at baseline, but not obese or diabetic, 94% were still potent 2 years following treatment. In the same group of patients, Dr. Hoppe looked at the risk of urinary incontinence, and we had a 1.8% risk of patients requiring a pad at 2 years following proton therapy. And then control rates. Again, we were interested in comparing our control rates to the IMRT, X-ray treatment control rates, utilizing that same series from Memorial Sloan Kettering. And in our first 3 trials, we saw no evidence of biochemical recurrence or clinical recurrence in 99% of our patients with low-risk disease, 99% in the intermediate risk group, and 76% in the high-risk group. And by comparison, the IMRT data from Memorial Sloan Kettering was essentially the same with the low-risk group. Their intermediate risk control rate was 85%, which is actually a good control rate for intermediate risk patients. But it was interesting to us. I mean, we could be criticized because in this comparison because our numbers were quite low. In our first 3 trials, they had less than 100 patients in each of those trials, and the numbers from Memorial are much more robust. What we've done since this time is go back and analyze our first 1,500 patients that we treated, whether they were on a prospective trial or not. And what we found was that in the approximately 600 patients that had low-risk disease, the control rates held up at 99%. The intermediate risk group, we had about 600 patients in that group, and the intermediate risk control rate was 95%. And so we were very pleased with that figure holding up 10% higher than the IMRT data from Memorial Sloan Kettering. It was also interesting that at Memorial Sloan Kettering, they were much more likely to add hormonal therapy to their intermediate risk treatment regimen. And about half of their patients got hormone treatment, which typically you think of as adding to the likelihood of having a control in intermediate risk disease. And at our institution, we typically did not use hormone therapy with intermediate risk disease, and only 10% of our patients in this category got additional hormonal therapy along with proton therapy. And then in the high-risk group, our high-risk control rates compare favorably with the IMRT data, but the high-risk control rates, I think when you look at results that are published, you have to be very careful because it really depends on how high risk are those high-risk patients. because it's quite different if you have a high-risk patient who's high risk simply because they have one high-risk factor. But if you have multiple high-risk factors, they may represent a much more difficult group to treat. So that mix of patients is quite important to tease out if you can do it. We also compared our results to the Memorial Sloan Kettering implant, radiation seed implant results. And that particular series had a 4-year median follow-up, and their control rate for the low-risk disease held up very well in comparison with the IMRT and Proton data. Their intermediate risk control rate looked excellent as well, 95%, which would be equivalent to what we saw in our patients. What we don't know is how they selected those patients. Again, selection, even with intermediate risk disease, you have favorable intermediate and unfavorable intermediate risk, and we don't know what their mix of patients was in that study. The high-risk results that they reported with their external beam radiation combined with seed implant look outstanding, at 80%, which is better than what we had at our institution, or with the IMRT results from Memorial Sloan Kettering. However, if you look at the paper, again, remember I said it's important to know how high risk are the high-risk patients, and it was striking when I looked at this. I found that only 2 patients out of their entire high-risk group treated with implant had more than one high-risk feature. And if you excluded those 2 patients, their control rate at 5 years was 82%. Almost unchanged, because almost all of them only had one high-risk feature. Our patient population had patients that had multiple high-risk features, and quite a number of them. And so if we excluded it to, or limited it to the patients who had only one high-risk feature treated with proton therapy, our control rate was 94%. We really don't know what the mix was in the IMRT series, unfortunately. And I might also mention, when we examined our first 1,500 patients, we had about 250 of them that had high-risk disease. And we're in the process of preparing a manuscript for publication on those 250 high-risk patients. And it was interesting what we found with those patients treated with protons. We found that we could separate out the ones that did better from those that did not by identifying through multivariate analysis several what we called very high-risk features. And that included the patients who had Gleason scores 9 and 10. That was one very high-risk feature. Another was a PSA above 30. Another was if they had more than 50% of the biopsy cores involved with cancer. And then the fourth factor was if any one of the cores had more than 50% tumor involvement. And if we looked at the patients who had no very high-risk features among our high-risk group, so they were the more favorable group, those patients had a 5-year control rate of 95%. And we found that it made no difference whether they were treated with hormone therapy or without hormone therapy. With hormone therapy, the control rate was 97%. Without, it was 94%, and not statistically significantly different. So potentially, those patients could be treated with proton therapy without hormone therapy. In the patients who had 2 of the very high-risk factors, the 5-year control rate was 75%. And in those that had 3 or 4 high-risk features, it was 30% control rate at 5 years. And that's a group that's going to need more aggressive treatment in some fashion. We also identified a group of patients among our low-risk disease patients who were potentially suitable for radioactive seed implant. Their prostate volumes were 60 cc's or less. They had not had a prior TURP. We felt that they were appropriate potentially for having a seed implant as their treatment. In that group, we saw no grade 3 complications, and the freedom from biochemical progression at 5 years was 97%. So what we would conclude is that our experience so far with proton therapy and the treatment of prostate cancer has shown us excellent early results, excellent early control rates. The toxicity rates have certainly been at least comparable to control rates with IMRT and other modalities, and some of the functional results look potentially better. The higher control rate with intermediate risk disease is intriguing, and we've begun to wonder if actually some of the assumptions about the conversion ratios of equivalency between proton therapy and IMRT are correct or not. It may be that we're actually giving a little bit more potent dose or effective with radiation than has been assumed. And at this point, we feel like it's an area of research and interest that appears promising. I think with additional data and additional follow-up, we'll have a better feel for where this might fall in the overall scheme of prostate cancer treatments. But at this point, we're excited about what we're seeing at this early stage. Thank you again for your attention, and I'm glad to answer any questions.
First, just a comment. I didn't see on your map, but there's a Proton Center going up down in Westchester by Cincinnati Children's is building one right now. It's under construction. And my question is more for the panel and probably specifically Dr. Ross. But if you have a person that you do a prostate biopsy on for elevated PSA, and maybe that's the only factor that caused you to do the biopsy, and it's negative. Does that have any what is the predictive value of a negative biopsy as far as follow-up? And is that like if you have a negative colonoscopy, you can go 10 years. I mean, if you have a negative prostate biopsy, does that have any predictive in the field of urology?
So it hasn't been very well studied, but essentially in the PCPT trial, which is the trial when they were using like finasteride versus nothing, looking at essentially if it could be chemopreventive. There were mandatory biopsies every 4 years, and it seems like the clock resets at about 4 years. So I think that we usually just put those guys back into PSA screening, and then if they have an elevated PSA, it depends where they started. If it was 4 or something like that, negative biopsy, I feel pretty good. Prostate volume was large. For some of my guys, now again, we have benefit from MRI. The PSA say 15 or something, we go to do biopsy, it's all negative. We recheck it again in like usually 3 to 6 months in my practice, and it's still 15. I think we missed something, and we do an MRI to look for an anterior tumor that we can target. But the initial question, I would say average risk guy, it may make them protective for about 4 years, although I think they should just go back into the PSA screening population. I would not treat that man with proton therapy.
Our best results are the ones that don't have cancer. Yes.
The percentage of maintenance of erectile function in these patients is astonishingly high. I've seen you refer to one study. Has that been duplicated in other studies? Any of these patients has been on hormonal treatment in addition to the proton? Because obviously some of them has been already on hormonal treatment. And if you operate on some of these proton therapy patients when they have recurrence, the idea is there is tremendous amount of fibrosis and scarring around the prostate, that all these areas of the neurovascular bundles, which we believe has a lot to do with sexual function, is almost totally scarred down. So I'm astonished about this relatively, any explanation why we have this excellent high percentage?
This is the only study that looked at patient-reported outcomes, and we'll be expanding. It's not the only time that we will look at that, but at this point, this is the initial look that we have with basically 250 patients. Why would it be as good as it is, or better than, say, with IMRT? One of the things that we're looking at in our patients is the penile bulb dose with proton therapy, and we're actually able to spare the penile bulb a bit better with protons than we can with IMRT, and there does appear to be a correlation. But we have, just with an early analysis, and I don't know if that's the explanation or not, the dose of radiation that we're giving is actually quite high. The two studies that I showed with protons and with IMRT, like the Memorial data, the dose of 86 given at 1.8 per fraction is not what you normally see given in the community. It's a higher dose, and yet that's, from a radiobiologic standpoint, is closer to what we're giving 2 cobalt gray equivalent per fraction to 78, which usually is not done in private practice, most private practices. So it is a more aggressive radiation. So seeing fibrosis is not surprising. Nerves tend to be pretty resistant to radiation. We don't know exactly what the mechanism of action is on the effect on the neurovascular bundle. I suspect it's probably more the small vessels supplying the nerves than the nerves themselves, because the vessels are certainly sensitive to radiation effect, and I don't have a better explanation for those results.
Just
Sorry.
just to follow up to that,
Yeah.
when you said return to baseline, that was return to baseline without any medications? In other words, when they went to like 94% return to baseline, they were younger men, was it baseline function without any PDE5 inhibitors? Because that might
No,
be the
they could have
difference.
had PD5 inhibitors.
And that might be one of
Yeah.
the differences.
And I think that's an excellent point. With surgery, it's usually the neurovascular bundle. With radiation, is usually the small vessels, and which are very sensitive to PD5 inhibitors. And you mentioned the penile bulb, and I know early on in my practice that was sort of a light bulb when I learned how to adjust my prostate contours, because it's very easy just to, when you're going through a CT scan slice, not really see the difference between the prostate and the penile bulb. And you oftentimes have to use an MRI atlas and when you're looking at CTs to see really what subtle differences in the surrounding musculature going from concave to convex really associate with the end of the prostate and beginning of the penile bulb. One way to make that easier is obviously to use MRI as part of your simulation process, or to fuse an MRI with your CT, and I was wondering if you did that at Florida.
We do, and that it is much easier to identify and contour that structure. So every patient we treat gets a CT sim and an MRI sim with fused imaging for treatment planning, and every patient has the penile bulb contoured.
My question would be, again, in primary care, what would be the compelling reason for me to try to tell one of my patients to go over to IU and live there for whatever 6 to 8 weeks to get Proton versus getting MRIT, radiation
IMRT.
here?
Yeah, I don't know that there is a compelling reason. I mean, I'm not here to convince you that proton therapy is the only valid treatment for prostate cancer. I think that we have a number of good options, and it really depends upon what the concerns are of the patient and how intrigued they are about the early results that we have. The erectile function results are very interesting, but will they hold up with larger numbers and longer follow-up? And I think that remains to be seen. Our toxicity, the rectal functional results hasn't got a lot of exposure, but I mean, those in the patients that are having rectal frequency and urgency and even potentially leaking some stool, that's actually a bigger deal than leaking a little urine. And so, how important will those issues be, I think, remain to be worked out with more data and longer follow-up.
And my second question would be, with any kind of radiation versus surgery right now, where do the recommendations break down on that, or is that still very much a personal choice?
Radiation versus surgery, I think that it does boil down to be a personal choice. You're offering a different set of potential complications. I think the surgeons can always offer longer term data on control rates, and so a patient who wants the best data on how he's going to be potentially doing 20 years down the road, the surgeons are going to have more data to show. We certainly don't have that. But I think if you're comfortable with having excellent data out as far as we have data, then patients, there are plenty of patients who like the set of potential problems that they might face with either IMRT or Proton better than they do the surgical risk. But that is from my standpoint, a personal decision.
What about using age as a criteria? Is that?
Yeah, that plays into age, the health of the patient, what kind of candidate they are in terms of risk with surgery. And most of the time when you get a patient who's getting up into their 70s and approaching 80, most of us are going to be thinking radiation and not surgery. and then you factor on top of that how healthy they are for their age, yes, that can certainly make a difference.
I agree with most that there's only been retrospective studies that have looked at the two, and none of these involve Proton. And so essentially, I think in those retrospective studies, which albeit most of them did not use IMRT with IGRT, in comparison, the oncologic outcomes seem to be a little bit superior with surgery. That all those studies, though, when they do an age cutoff, it's restricted to younger men. So for men over 65, I don't think there's a clear benefit. Maybe if they have very high-risk disease, you could consider it because you can give adjuvant radiation afterwards. But for men over 65, usually not a clear benefit. Marty Sanda did a study where he looked at kind of quality of life issues in men, and after 2 years they kind of normalized, but for the first 2 years, the quality of life of people who had radiation was a little bit better. And so for the older patient, I usually counsel them that, really, unless it's a personal choice, in terms of you want the cancer out of your body, in that way, instead of radiating it, you may do better and oncologically similar quality of life better with radiation if you're older. For the younger patient, I honestly worry a lot, particularly for men under 60, about secondary malignancies. But Proton data is pretty compelling even where they're delivering the dose, and so maybe that won't be a concern. Another issue of concern sometimes for me for the younger patient is they're very rare to have serious complications from radiation. It's fairly rare. But if they occur, that tissue is fairly damaged, and it can be hard to manage them. So in that really sub-fraction, if you're one of those unlucky few, then that's a problem. Obviously, there can be major complications from surgery too that are rare. But so I do use an age cutoff, but.
Did I hear you right in your talk earlier that for men under 65, watchful waiting wasn't a good idea?
No, well, there's two things. There's two parts of that. One is just the differentiation between active surveillance and watchful waiting. Watchful waiting, which was used in the clinical trials, was actually waiting until the man has metastatic disease and then treating. Active surveillance being waiting until they have kind of higher risk disease and then treating, but localized still with the intent to cure. And so for active surveillance, which I think what you're referring to, I think it can be performed in younger men. The data is not as robust because we just had not done that as traditionally. So you just have to be more cautious. And that's why for some of these newer tests, if we have an older guy, say a 74-year-old, 75-year-old, who has very low risk prostate cancer or even low risk disease, there's basically no question that guy can defer treatment. But if you have a guy who's 55 with low risk disease or very low risk disease, you get kind of worried because there's no clinical evidence. Maybe you should use a newer test. The other thing to sometimes think about is for the young man with low risk disease, if they're treated up front with say surgery, usually you can try to do very rigorous nerve sparing. They're younger, their recovery is going to be easier. And from the radiation sphere, again, with the caveat of not talking about Proton, but say the disease is low risk or very low risk, and they want to do brachytherapy, which may have some of the best functional results, they can do that. If you wait till they progress on surveillance, then they may be looking at having bulkier disease, requiring more nerve taken, having adverse pathology afterwards, and needing adjuvant radiation therapy. And so there's a risk benefit there too. And so in some ways it is personalized. I think Dr. Keeler said it well last night when we met each other. He's like, a lot of it was the patient deciding for themselves, and you just have to give them the data that you can.
Can I add just one more point? So when you place a 55-year-old on active surveillance, that patient is going to get treated over the course of their lifetime, almost certainly, because any of those things is going to happen. Either grade gets higher on repeat biopsy, or the PSA goes up, or they just get nervous at some period of time. It's pretty much never that you are never going to intervene on a 55-year-old who is going to have prostate cancer, whereas a 70-something-year-old, maybe very legitimately you will never treat them because they'll die of something else. But we do put those 55-year-old patients sometimes on active surveillance, just to give them a treatment-free holiday for some number of years, as long as you watch them very closely. But the risk that you run is that the treatment modality that you might need to use to then control their disease might be more toxic as it goes along, and especially if a 55-year-old has a lot of comorbidities, you actually might prefer treating them earlier rather than later, because the comorbidities might even advance more quickly than the cancer. So the active surveillance discussion in a young patient is really quite complicated, and really the goal of active surveillance in a young patient is to defer therapy rather than to save them from therapy completely. Would you agree?
Yep.
There we go. So I'm going to ask, you've had a slide where you mentioned the second malignancy risk with radiation therapy. And I know there's also been a retrospective SEER analysis showing increased rates of colon cancer after radiation therapy for prostate cancer. But one of the confounders that I noted, and it wasn't clear in your slide, was that there's a baseline risk of colon cancer in all of these people. So it was about a 1 in 500 risk of getting a colon cancer over that 5 years, and I know that was over 10 years, the slide you presented. But when they looked at the baseline colon cancer rate, it was 1 in 1,000. So it doubled over the baseline, but it was still a small fraction increase. I didn't know if you knew whether that slide, that data incorporated the baseline cancer risk for the population.
I don't recall. I don't recall the answer to that.
Can I make a comment? And this might be just me off the rails. There's very little hard data on actual cancer, secondary cancers in a lot of radiation studies. I mean, I think the best data is with Hodgkin's disease, where you're really giving a very high dose, and those patients were treated in the 70s, and you have like 30, 40 years of follow-up to have hard data. But here, I don't feel like we have great data on what the secondary malignancy rate is for prostate radiation. And a lot of this data is based on modeling, and it's the same sort of idea with people giving cancer risks with frequent CT scans, is that it's based on a lot of modeling, and it's really not a lot of hard data in terms of percentages. So I think that there's a lot out there that we really don't know.
Yeah, even the 10-year data is pretty short for radiation secondary malignancies.
Even for rectal cancer? Even for rectal cancer?
Well, not
10 years? Or?
Yeah, if you're looking at sarcomas, which are more common kind of radiation-related malignancies, and that rate doesn't decline as you go out from 10 to 20 to 30 years.
Well, thank you very much for a very
Sure.
interesting talk.